Hello, everybody. Welcome to Symmetry's webinar. We're going to get started here in just a minute. We're going to wait for everybody to get into the room and get their audio connected. While we're waiting, I'm Missy Gilliland, the Director of Learning and Development here at Symmetry, and we are very happy that you could join us today for our webinar as we look at how to prevent lost revenue. If you have any questions, please feel free to use the Q&A. I will be posting the handout in the chat here in just a moment. But with that, I'm going to go ahead and turn it over to Brian to get us started today.
Thanks, Missy. And I'll echo what Missy had mentioned. I appreciate everyone joining us today. Hopefully you got a nice lunch in front of you if you're on East Coast time like I am right now, that we can sit back and really dive into unbilled reporting. So we've got half an hour to chat through this here. So we're going to move through some concepts for both the home health and the hospice end. I want to try to make sure we leave some time for questions at the end. But really, at the end of the day, and we can flip to the agenda here, we want to look at best practice metrics for unbilled claims. Anytime we talk about accounts receivable or cash flow or getting claims paid, the first step of that is actually getting it out the door. And we see a lot of times that agencies struggle with that, where you might have good collections practices on the back end, but there's a lot of claims that are held and aren't even getting billed, and then you start running into timely filing risks. So we want to make sure we understand what best practice looks like. Understand the pre-billing requirements, what could potentially be holding up claims, and what should you be looking for during that pre-billing process. And then developing recommendations. The goal this year is not to just dump, hey, here's all the issues that you can potentially run into, but we want to try to give a little bit of insight as to what we've seen be effective to help your agency manage its unbilled activity. So if we want to kick off here, looking at some benchmarks, kind of starting to lay the ground of what do we view as benchmarks for unbilled. And really just starting with some definitions. And anytime we're talking about unbilled activity, it's really held claims. It's claims where the service period is completed and you're unable to submit it to the payer. That could be held in your EMR, it could be held in your clearinghouse, or through some other edits that you have going. But we really want to take a look at that. And again, it's on the home health side. Your PDGM 30-day period is completed, try to bill your final claim, but you're not able to get it out the door. Hospice, the month is over, same thing. Any of your managed care per visit payers, you got visits done that you're not able to bill. It's really taking a look at that unbilled activity. And the second bullet here is stating the obvious a little bit, but if you can't get claims out the door, that could have a negative impact on cash flow. We know just from a margin standpoint, the industry is facing some really tough challenges today, that it makes it even more important that you're collecting on every dollar that you bring into the organization, and that you're collecting on it in a timely manner and not experiencing any delays that could be preventable. At the same time, timely filing limits. We know you have up to a year with Medicare, but you might have some managed care plans where you only have 90 days to get those claims out the door. And it's really tough if you don't bill the claim timely to turn around and get that paid. So anything you can do to streamline your pre-bill processes and mitigate any unbilled issues, the less chance you'll run into those timely filing. Really, when we talk about looking at accounts receivable or your AR, we do look at that as unbilled versus billed. I mean, it's great to look at billed and know what your collectors need to go out there and follow up with the payers on, but you want to make sure there's visibility there. I think that's the biggest challenge we see a lot of the time too, is that we know that we're struggling with claims getting out the door, but we don't have visibility into the reasons and the why. So what you really want to do is, I mean, primarily leverage your EMR for that. You want to have it tracked. You want to have dashboards if possible, that can so you can understand what is holding up these claims. And more importantly, who needs to fix that? Is this something that our billing team can do? Do we need to reach out to our clinical operations team? Is it an orders issue that's someone in medical records? We need to work on getting some signatures. You want to have a really strong process for understanding, here are the issues that are holding up claims, who is responsible for those, and what is the communication between your billing team and the folks that are responsible for getting that done in a timely manner. If we jump to the next slide here, just wanted to give a best practice benchmark that we use. And this one's always a little bit wordy, so we'll send you out the slides. You can make sure you read through it if I fumble through the words here. But what we look at is unbilled AR over 30 days being less than 10% of your average monthly revenue. So we give a little bit of a visual down there, down below there. And why we look at unbilled over 30 days, there could be something where your PDGM period just ended, you're trying to bill 5 days afterwards, and you don't get the physician's signature back until 7 days afterwards. So there's a little bit of a delay there. And frankly, once you hit month end, your unbilled is going to shoot up for a couple days before you run that month end cycle. So it'd be a little bit inflated if you look at that. We really view that 30-day benchmark where if you're 30 days past the dates of service or past the billing period and you still haven't gotten your claim out the door, that's an issue. And that's something that you want to escalate and take a look at. So the example that we give below, and I'll use some round numbers here, is that if you have $100,000 in average monthly revenue, your unbilled AR aged out over 30 days should be less than 10 grand. And if it's higher than that, you really want to drill into that by reason. And we do recommend looking at that daily. So again, want to try to give some benchmarks that you can aim for here. And again, really focusing on if claims are getting out to that 30-day mark and we haven't billed them yet, what are the reasons why? We mentioned this a little bit, but looking at it by reason, it's one thing to say, hey, we've got $100,000 in held claims, but if you're not sure what the reasons are, it's really difficult to dissect that, diagnose it, and ultimately get the claims out the door. Big fan of dashboards myself, in that it gives some good visuals. It can draw your attention to where you need to be instead of having to weeding through maybe dense data sets here. You want to make sure you have that backup, but if you look at simple pie chart on the right there, looking at, hey, 60% of our claims are held due to orders. And we're going to go into that a little bit throughout this presentation, because typically when we see held claims issues, unsigned orders are the biggest problem behind that. But really being able to take a look and again say, hey, we got $100,000 in held claims. This much is due to orders. This much is due to face-to-face. This much due to OASIS on the home health side. This much due to unverified visits. Really understanding that. And again, coming back to the concept of, okay, that's great that we know why claims are being held. Now, who needs to fix that? At the same time, that needs to be done. That needs to be part of your billing process, but use that opportunity to be proactive. If you look and you're saying, hey, constantly I look at this pie chart and we have 75% of our claims held due to orders, they're aging out over 30 days, that might be a sign that you need to go back and take a look at your orders tracking processes. Go back and take a look at how quickly are we getting them out? What's our follow-up process for the orders? And again, we'll make some recommendations on that a little bit later on in this presentation, but use this as an opportunity to both clean things up in the current state, get them out the door, but proactively address issues up on the front end that could be impacting this. Again, I think there's a misconception sometimes that if claims aren't getting out the door, it's an issue of the billers not doing what they need to do, but really billing is the catcher's mitt. It really is a reflection of everything that's happened beforehand, both from an operations and a care delivery standpoint and the front end revenue cycle. It's the biller's primary job to be communicating on these, but we need to make sure that communication and accountability is there on the folks that need to resolve these issues as well. Talked about orders a little bit, did just want to give another benchmark throughout the course of this. Similar in nature, but if you look at outstanding orders, our benchmark is less than 10% of outstanding orders being aged over 30 days. So again, same concept. It might take some time to get the order out to the physician, get it signed on the hospice side, to get your CTI signed, but you really want to start escalating that out over 30 days because that could be an issue. If you look at a PDGM period, theoretically you have 30 days to get that order signed from the start of care before you're starting to bill that first final claim. So you want to be proactive in getting those out the door, but really escalating them once they're past that 30-day point since the order was created. For documentation and visits, again, looking at who do we need to communicate with, you want to follow up with the clinical staff on outstanding items and let your technology work for you. There should be reports in your EMR that you're running. What you don't want to get into is one-off frantic emails going back and forth. The best that you can consolidate it. We mentioned communication from the biller's end being important. If you can consolidate this information and deliver it to the accountable parties in a digestible format, it makes it a lot easier for them to work through it. There'll be less of an antagonistic relationship because they'll look and say, hey, we know this needs to get done, but billing's putting it up on a T for us, and all we need to do is knock it out. So again, long-winded way of drilling down to it of, hey, you need to look at your total unbilled AR, but also what are the key reasons and how can we both address what's there right now and proactively address the processes on the front end. So we want to dive into a little bit. We'll start with home health and go into hospice, just really lay out the potential issues that could be holding up a claim. So we jump to the first slide here. Just wanted to list these out. Again, the pre-bill requirements. And a lot of these we're focusing on the traditional Medicare standpoint. You might see these with some of your Medicare Advantages, even your traditional Medicaid, but really looking at the traditional Medicare standpoint here, signed and dated orders and plan of care. And again, we'll go into that a little bit more, I believe, on the next slide. Make sure those consents are completed and signed. Face-to-face, that you have that encounter note, that the encounter was done in the requisite time frame. So either that 90 days before or 30 days after the start of care, that the OASIS was submitted and accepted by IKEYS. We are seeing a little bit less flexibility with timely submissions of that now that we're coming out of the PHE. We're seeing more claims issues on the back end if that OASIS was not submitted timely. So you want to make sure that you're both submitting that timely and that you're monitoring rejections. It's one thing to submit it, but if the OASIS comes back and gets rejected upon the IKEYS upload, you want to make sure you have a process for addressing that right away. Locking and verifying visits, you want to make sure there's a timely process for that. And if you're lucky enough to be joining us from any of the 5 states listed there is that additional step of review choice demonstration. And while, I mean, we're not going to go into all the details of that right now, there's opportunities to streamline that. That still represents another potential delay in getting that UTN and getting your claims out the door. So again, just wanted to call this out. Again, these are compliance items here. So these need to be done. There's not really any corners to cut with what you have here. So you need to make sure you have strong processes. And at the same time, and we call this out a little bit below, utilize your EMR for this. In order to streamline this, your EMR should have edits that capture all of the items that we have listed above, or at least the majority of them. If they don't have everything and you need a little bit of review there, you want to make sure you're minimizing that, because at least the key items that we have here should be automated in your ability to see what's held versus not. What you really want to avoid is manual pre-bill reviews. We've worked with a lot of organizations that are delayed in billing by sometimes a couple of weeks because every single individual claim is manually touched. And when we have conversations and go through the audit, there are points in the EMR for everything that's being manually reviewed that the EMR will do for you just automatically. So we understand a lot of the conversation sometimes is you want to be overly cautious with the compliance, but at the same time, if you do an audit and find your EMR is holding everything you would have held manually, all you're doing is delaying getting that claim out the door, delaying getting that claim paid, and frankly, you're using more resources on the billing process that could otherwise be placed towards collecting on outstanding AR and working on issues when you get the claims out the door. So really recommend that there. And at the same time, just making sure you're not duplicating efforts. If you have billers going in that are doing the same reviews that the clinical ops team have already performed, that's duplicating efforts for an audit that was already completed. So again, that's one of the big recommendations coming out of this. Let technology work for you. Make sure all of these requirements that we have here are accounted for, but that you're not having to do manual reviews in order to push things forward. So if we jump to the next slide here, again, wanted to touch base on orders tracking. We're working with a lot of our clients right now on some of these engagements, both from just a strategy standpoint and just from a, hey, we know we need to knock this out. We don't have the resources. Let's make sure we get an infusion of resources in here to push these things forward and get these orders signed. But typically, if we have the conversation with the client of, hey, why is your unbilled AR so high? The answer we get back is unsigned orders. That's by far the most common that we see here. So we talked a lot about some of our benchmarks there. I think we all understand the importance of it, but did just want to call out a few key pieces to the proactive process improvement that we talked about earlier. Listed out here a recommended follow-up method where really all these bullets dial down to following up with a physician every 7 days. So you get an order out the door. Every 7 days, you're calling the physician or the physician's office. If you need to get in touch with someone that can really help push these forward, calling, refaxing, or resending the orders as necessary. And then by that day 30, you're already at an escalation point where you followed up several times. If you're not getting responses, you enlist liaisons or you get someone else involved from a higher level to really come and escalate getting these orders signed. This again, for the point of 30 days is kind of that mark with the orders where we say, okay, we got a problem here. These aren't signed. That if you can have this escalation process and you're following up and you can build those relationships with the physician or the physician's office or facility where they're at, that should really help mitigate the extent to which orders are impacting your held claims. We gave the benchmark there again of the over 30 days, but at the same time, track and trend outstanding orders by physician. So instead of having, if a physician has outstanding orders for 5 patients, instead of making 5 calls, call once and say, hey, here's everything that we have outstanding, streamlines things for them, streamlines things for you, and helps you get those claims out the door a little bit quicker and also maintain compliance there. But really looking at it, if you see physician Harris has 35 outstanding orders and the next highest physician is at 10, you're going to be calling physician hires a lot more often than the others because there's clearly a problem there. And if you can make one phone call and get 35 orders back, streamlines it a lot. So wanted to give a little bit of insight as to what we view as best practice there. And again, close out by really stressing, you want to make sure you have dedicated resources to this. While this is the most common held claims issue that we see, this is also the function that most times when we go into organizations and we ask who's doing orders tracking, it's someone's fourth priority of their job. It's, well, they have to triage phone calls and they have to file ADRs when they come in and file medical records. And then whatever time they have left, they're doing orders tracking. And then you find that amounts to 4 to 5 hours a week. And that's not nearly enough time to keep on top of this. So on top of the process items that we have here, really just want to recommend, look at who you have assigned to it and make sure you have dedicated resources, and that'll flow all the way up to the timely submission of claims. That is the crux of what we're talking about here. If we look at claims submissions themselves, so you clear all these pre-billing edits, want to make sure you're submitting claims electronically. Get rid of the snail mail, make sure you're set up in the clearinghouse to do everything that you can. It's the most efficient way to get claims on file and processing. You have that timestamp so that you can confirm if a payer claims they never received it, you can go into the clearinghouse, get that timestamp and really support timely filing. While at the same time, make sure you're monitoring clearinghouse rejections daily. So again, it's one thing to hit send on the claim or upload a batch, but if all the claims come back rejected, that doesn't count as being on file with the payer. So you want to make sure if you're looking at that daily, you're addressing issues, you're getting things out the door, and they're not piling up. Again, the first step to getting paid is actually getting that claim on file with the payer. You want to make sure you're looking at those rejections once you can finally get the claim out the door. That counts a lot too. We look at the frequency down below for notices of admission on the Medicare side for home health. We know we have that 5-day window, and if we don't get it in time, we risk writing off some of those days. You want to make sure you're submitting those daily, and that you're submitting those daily, you're monitoring those daily, working RTP claims if it's on the Medicare side. Again, submitting the claims is one thing, but until they're in processing with the payer, your job as a biller isn't done. So you really want to make sure you're monitoring those. In terms of the frequency of actually submitting the claims, we do recommend daily for any PDGM reimbursing payers. So basically, as these 30-day periods are ending, you're looking to run daily cycles to get those final claims out the door, and also submitting those NOAs daily. For your fee-for-service payers or your per-visit payers on the home health side, we recommend monthly claim submissions. So if I'm billing for May, I'm going to wait until May is done, bill all those claims out the door, bill all those visits out the door on one claim, and look to submit that way, doing one month-end cycle and then doing subsequent weekly cycles after that for anything that wasn't able to be billed initially. It allows all visits to be on one claim. We have seen some providers that have billed weekly to try to accelerate that cash flow. Part of the concern with that is if there's issues or denials, now you're having to send appeals or send corrected claims on 4 claims a month instead of 1 claim a month. And we also do see some erroneous duplicate denials occur if there's overlapping dates of service on the claims that ultimately impact cash flow, even though the intention is to accelerate it. So we do recommend those monthly increment claim submissions, really streamlining things, making it easier and less volume to follow up on the collection standpoint and the cash posting standpoint. But again, following the same concepts of clearing those pre-bill issues in a timely manner. So if we jump to the next slide, we're going to walk through hospice in the same manner that we just talked through home health. You'll see it's fairly similar. So for the pre-bill requirements, the big one being the CTI, along with that attestation statement, the appropriate narrative within the CTI. Did want to call out the initial CTI has to be signed by the attending physician and the medical director, but for any subsequent benefit periods, you only need the signature from the medical director. So once you get past that first 90 days, it makes it a little bit easier to get those CTIs signed and dated and get your claims out the door. On the face-to-face standpoint, we mentioned this on the home health side, a little bit different on the hospice side. The encounter has to occur no more than 30 days prior to the 3rd benefit period and each benefit period after that. So again, same concept as the home health side. The timing is a little bit different. You don't need it for the first 180 days. But if you look at really the rules and the core pre-bill requirements on the hospice side, pretty similar to home health. The only main difference is orders are not required to be signed prior to billing. It's really just that CTI and the face-to-face that are the core items. We jump to the next slide. Looking at claim submissions, all the same concepts we talked about with plans of care and orders on our process there, we'd recommend the same thing for CTIs. But if you look at the actual claim submissions on the hospice side, billing should be performed on a calendar month basis. And frankly, that's how Medicare requires you to do it. You can't really split up the month of half of May and then the next half of May. But really, again, do that month-end cycle and conduct subsequent weekly cycles to capture any claims that were previously held. So you should get the bulk of it out. It's usually a timing game with hospice, right? Where you try to get your pre-bill errors cleared earlier in the month so that you can get that big check at some point a couple of weeks into the month. But you want to make sure that you're doing those subsequent cycles for things that were held. Again, we do recommend monthly here and then subsequent weekly. If you're a larger agency and you have a high volume and you say, hey, I want to go 3 times a week to try to get those out the door and not wait a full week if I get something done right after the cycle, by all means do that. I think we view this really as a minimum that you should be doing. One other consideration, again, if you have the volume and you've got a good process in place, is mid-month, you can't split dates of service for the month, but if a patient revokes or a patient passes away in the middle of the month, having death and discharge billing cycles prepared, that mid-month you're looking and saying, okay, anyone that was discharged in some fashion over the first half of the month, I'm going to look to bill those claims, assuming they're passing edits on the midway point of the month. That could be a way, again, get some claims that where the patient's no longer on service out the door a little bit sooner and accelerate that cash flow a little bit more. Obviously, on the hospice side, we're dealing with sequential billing, and that the previous month's claim needs to either be processed or in processing. So you can actually submit those to Medicare as long as the first one gets in processing first. You can get all the other ones out there if you've got a few backed up and they'll kind of fall in line. But you want to make sure you have that in mind. If you are to submit a subsequent claim before an earlier claim, you're going to run into issues with processing, with RTPs, potentially having to back out the later claim and then bill the earlier one. And frankly, it just delays your ability to submit claims and get those out the door. In terms of the qualification of being considered processed, if a claim is rejected or denied, that is considered processed. You can get that sequential claim out the door beyond it. It doesn't just have to be in a paid status on the Medicare side. So really managing that, again, on the hospice side with the sequential billing, you could clear one held claim issue for CTIs and get 3 months worth of claims out the door. So makes it even more important that you're monitoring that. And then on the HIS side, I just want to call that out, that hospices are required to submit both the admission record and the discharge record for each patient, regardless of their payer source. Hospices that don't comply get hit with a 2% reduction in annual payment. And actually in the recent proposed rule, they propose, or CMS proposed, to increase that to 4%. So that's a little bit different necessarily than claim submissions and what we're talking about with held claims, but very important to have a timely process in place there, as it could ultimately impact the reimbursement that you're receiving. So best practice, we talked about this a little bit, but going a bit further. Same with the NOAs, you want daily NOE submissions on the hospice side. There's the same 5-day timely filing and potential penalties there. You want to make sure you're submitting those daily, monitoring rejections if you're submitting electronically, monitoring RTPs daily for both the NOAs and the NOEs. You want to make sure you're looking at that daily, because if a claim's an RTP, it's not considered as being accepted for processing. So you want to make sure you're addressing those, whether it be overlaps or other issues, that if you submit your NOEs, that you're checking the next day to make sure they got in. You want to make sure all visits are completed and on the claim prior to billing. We mentioned that as a requirement, but on the hospice side for Medicare, that could also impact your service intensity add-on payments. Again, those are those RN or MSW visits in the last 7 days of a patient's life. You're going to get additional reimbursement if those are on the claims. That from both a compliance standpoint and a reimbursement standpoint, you want to make sure you're not sending out claims before those visits are verified. At the same time, medications, you're required to list those as a summary 1-line item for patients on the claim, includes injectable medications, infusion pumps. You want to make sure you have a good process there where those meds are getting into your system. If there's any sort of upload you're doing, that they're getting recognized, reconciled, and that they're getting onto the claim. Again, that is a requirement that CMS has for Medicare submissions on the hospice side. You want to make sure you have a good process in place and that that's not delaying your ability to get these claims out the door. So if we jump to key takeaways, I know we got about 5 minutes left here. I want to leave a couple minutes for some questions. But if we jump to the next slide here, At the end of the day, all of this, the key takeaway is monitor and proactively address unbilled AR. Again, you want to look at your AR, you want to look at what's out the door. We can tend to get held up with payer processing issues or key trends that are impacting claims once we submit them, but you can't lose sight of your unbilled AR, and you want to make sure you have strong processes for working to get those claims out the door. Track and trend the unbilled AR. You want that visibility. Again, I mentioned I love dashboards. It's a good visual that can point you pretty quickly to what your core issues are. And at the same time, it's one thing to have the data, but you got to act on the data. You got to understand who's responsible for fixing it. You got to understand how the teams need to collaborate to communicate on the issues, to get these addressed, both in the current state to clear any backlog of held claims, but also how can we work together on process improvement and communication where that there's less claims that are getting held once they're ready to bill. Did want to call out our benchmark again there that unbilled AR aged over 30 days should be less than 10% of your average monthly revenue. If you want to benchmark for looking at your unbilled AR volume, again, I'd be naive to sit here and say that you're going to have no unbilled AR over 30 days, especially, I mean, orders tracking can be complicated. There could be other issues, especially if you have a large volume, but you really want to mitigate that unbilled AR that's over the 30 days. At the same time, we talked about orders a lot, prioritize communication to physicians that have the high number of outstanding orders. And really, I mean, at the end of the day, orders is a compliance piece. So you need to be working through everything, but also prioritize the orders that are holding up claims. You ultimately have to get around, follow up, get everything signed. But if you have one order that's holding up 2 BDGM claims, make sure you get that signed. There's a quick way to get your claims out the door and get some claims paid. And at the same time, on the NOA and the NOE front, submit those daily, monitor those daily. The last thing that you want to do is run into issues where it's tough enough to get your final claims out the door, potentially running into some issues on the back end there that you don't want to be losing out on reimbursement there because there's gaps in the process for the NOAs and the NOEs. So with that, wanted to leave a couple minutes for questions here. As with everything, we tried to boil down a potentially complicated topic into a quick 30 minutes here, but we're working with both home health and hospice providers on a daily basis on these items, and we're happy to connect with you after this on any questions we're not able to address today.
So far, Brian, we don't have any questions in the Q&A, but if anybody does have a question, please don't hesitate to put it in the Q&A. We're really glad you guys could join us. The recording and the handout will be sent out to everybody in the next, usually it takes about 2 to 3 days. So look for that in your email. I don't see any questions, Brian, but we really appreciate everybody joining us. This was great information, Brian. Thank you so much for sharing it with us. I hope everyone has a wonderful day. And as always, if you have questions or need any help with your AR, we are here to assist at any point in time. So thank you guys.
Thanks, everyone. Have a good day.